You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, I'm Dr. William E. Morgan, and welcome to Clinical Rounds. Today I have a very special guest who's returning for another episode, Dr. Robert Traeger. Robert, thank you for joining us.
Thank you so much. I'm really happy to be here.
So where do you practice, and what are some of the passions you have of life?
Well, right now I'm working at Connor Whole Health University Hospitals in Cleveland, Ohio as a chiropractic physician and part-time researcher. Two young boys, and I love playing with them, hanging out with them, and on all that good stuff.
Fantastic. So today we're going to talk a little bit about how do we evaluate and examine and treat patients who've already had spinal surgeries. So when a patient walks into your office and you review their case and realize they've already been operated on, how would you treat that patient?
Well, I get a lot of information from the history actually that guides my treatment. And so the number one question that I always ask patients that have had a lower back surgery and they're returning with some sort of lower back pain or sciatic pain, I always ask them, what were your symptoms before the surgery and how have things changed since the surgery? Because patients can have a recurrent issue that they had treated with the surgery, or they can have a completely different issue, or they can have what we call adjacent segment disease. So there's a lot of things that go on, and the newer term that's being proposed for this is called persistent spine pain syndrome, or PSPS, or type 2 if you've had surgery. There's a lot of terms for it. They used to call it failed back surgery syndrome, although there's an awareness now that that's kind of blaming the surgeon, and it's not really the surgeon's fault. And there's a lot of things that can go on. I mean, people can get a lumbar fusion, they can slip and fall on their back, or they can have a lot of comorbidities, and maybe they're overweight, or maybe they smoke and they're had a higher risk of disc degeneration. So there's a lot of things that can go on, and just trying to tease that all apart and figure out what is generating their pain, and is it a structural issue, a mechanical issue? Is it something more like central sensitization, or some other kind of comorbidity that's getting in the way of them recovering? And it can take a year or even more for patients to get some of their nerves to start healing and some of their symptoms to go away after they've had a surgery. And so trying to put the patient in sort of your mind and figure out where they are in terms of their recovery, or sort of a recurrence or persistence of their symptoms after the surgery. And that's the starting point.
So as they come in, and there's, of course, if somebody comes in a month after their surgery, you're going to treat them a lot different than if they came in 2 years after their surgery or 5 years after their surgery. So with it, let's say, and as you know, let's say there's a disc herniation and that it's filled in with scar tissue in the same place that the disc was. Now you have scar tissue that's filled in the space where the herniation was. What would you do for a patient like that? And how would you find it?
That's a great question. Well, a lot of times, if you have a patient coming in with this sort of symptoms after surgery, I mean, you may or may not have imaging, right? And so you use similar guidelines to determine if you need to get new imaging, if they have severe neurologic deficits, and if it's been a while since the surgery and you'd expect them to recover and they're still not getting better. But I mean, there are a lot of precautions when you're working with a patient that's had a prior surgery. As a chiropractor, a lot of manual therapies and things that you want to be a little more gentle or cautious with. And it does depend on the type of surgery. I mean, some of these minimally invasive surgeries like a microdiscectomy, it won't influence what you're doing too much. If a patient had a laminectomy, it might influence what you've done a little bit with treatment. And then things like fusions with instrumentation across multiple levels, that will definitely impact what you're doing, or I would suggest that it probably should kind of impact your choice of treatment.
So do you use MRIs with and without gadolinium in post-surgical patients?
That's a great question. So I have ordered MRIs with gadolinium, but I do not like to, after seeing some of the research about how it could potentially be dangerous in triggering autoimmune conditions. And I sort of leave that up to the surgeon to determine if they want to do that. Because I know it is recommended after surgery, if you're going to have a repeat MRI, the gadolinium will help to show some of the scar tissue. But is it necessary? I'm not 100% sure. In all cases, it's absolutely necessary. There are other forms of imaging too. I mean, CT scans can be useful sometimes, as well as dynamic radiography, like flexion extension films can be helpful to show adjacent segment disease. And what that is when you have a segment that is fused or fixated, it's lost its capacity for intervertebral motion. And so the segment above, superior to that, or below that, immediately above or below, will have increased biomechanical load and movement and can wear out after about 10 to 15 years and get degenerative disc changes at that level. And so you need to have a heightened awareness for that, because these people might have some instability there. And so you might need to get some dynamic films. And so sometimes a radiograph will tell you more than an MRI, unless you have a dynamic MRI.
Yeah, X-rays and MRIs aren't always, like for diagnosing spondylolisthesis, MRI is not the preferred method. Actually, CT or X-ray is preferred over MRI for that diagnosis. So how would you modulate your care for someone post-surgical? What would you do differently for that patient than someone who had a spine that had not been operated on?
Yeah, it's a great question. And I think we can break it down by sort of technique. And if we want to tackle the spinal manipulation, I think there's a lot of considerations there. And there's really no guidelines or not a lot of research on this for chiropractic or spinal manipulation in general. What do we do when someone's had a fusion? And there was one sort of expert panel of a small group of experts. They rated spinal manipulation as appropriate for patients that had a laminectomy. And Dr. Clinton Daniels did a survey on Veterans Affairs providers, and the results were kind of mixed with regards to fusion. And I want to say over half of the chiropractors said they never or almost never did thrust manipulations on patients' lumbar spine that had a fusion. And then we have some case series that are showing that flexion distraction is actually possibly quite useful as far as diminishing pain severity in patients with prior lumbar fusion. And the approach that I use in the hospital, I use a lot of mobilizations on patients with prior surgeries, especially fusions. I typically don't do like a side posture manipulation on people that have had a laminectomy or fusion. Or even a discectomy. I typically do everything more gently in that case for people that have had a previous surgery.
I've adjusted. I was in private or clinical practice for 33 years. I would adjust them. But what I like to do is of course always go away from lesion. Especially you want to make sure it's healed up. There's a point of, I know Jay Triano recommended not adjusting or working on anybody manually for 6 months after a surgery at least, and longer may be better. But I've had neurosurgeons who've had refer to me a patient like this patient they operated on, they reherniated at the same level, and I've got them within a month. And I used Leander table, real gently working them, used some therapy, just basically helping them along and allowed that to reabsorb. But how I would do it would put them in a side posture, do some oscillations and not flex it, not twist it too much. I usually put the thoracic piece where it'll drop away, do some oscillations. How's that feel? That feels bad. Don't adjust. Put them at a different angle. That feels good. That makes, or it centralizes my pain. Maybe you can go ahead and do a gentle adjustment, but start light and gradually work your way up. Don't swing for the fence on anybody who's really has a hot disc or surgery. Would you agree with that?
100%. I think that's totally reasonable. They call that the pre-manipulative testing, and you can sort of put a patient in that preload position and see how it feels. And like I said, there's really no guidelines on this. I mean, we're all just doing what we feel is most appropriate, and we need to tackle this and study this as a profession. And that's where some of our research is going right now is how are clinicians approaching and treating patients with persistent spine pain after lumbar surgery. And so the results are not 100% in, but there are about 100 cases out there of patients getting spinal manipulation after they've had surgery. The other thing that I like to do is dry needling. And we utilize that. It's a technique of inserting a thin monofilament needle into the muscles to release tension and inhibit nociceptive signaling or pain. and stimulate blood flow. And when you have patients with chronic lower back pain or sciatic pain, even after a surgery, there can be a lot of guarding or spasm in the muscles. And so sometimes just simply breaking that up with the dry needling and maybe even going into the gluteus medius or the gluteus maximus or any of the areas that they're getting pain referral or radiation can be extremely helpful. And the other thing we use that to target is this cluneal nerve entrapment.
Oh,
and
that's a great topic.
Yeah. So some of the post-surgical lumbar spine research is showing that a lot of patients are getting this peripheral nerve entrapment, which runs from the lumbar spine anywhere in the lumbar levels, basically down to the sacrum, and it emerges over the iliac crest.
Yeah,
and there can be, oh yeah.
And the medial branch goes through a very tight fibrous tube, and cluneal nerve entrapment, and then Main syndrome. Are you familiar with that?
To my understanding, Main syndrome is almost the same thing as a cluneal nerve entrapment, and maybe there's some subtle differences, but like you said, I mean, there's an osteofibrous tunnel with some muscle attachments, and you have these nerves that are descending down, and they're simply getting entrapped. And anytime you have a surgery, I mean, there's going to be an incision, there's going to be some scar tissue. You can palpate it. I mean, when you try to stick the dry needling needles in there, sometimes they will just bend. They won't go in because, I mean, it's just so hard. And so that's something that I felt before as well. It's just very interesting. And so we try to loosen that up. And is that the mechanism? It's hard to say. You know, there's some non-specific effects of manual therapy as well. I mean, so just working on someone's back, you could be blocking pain signals that way too.
So Main syndrome is, I think it starts at T11, 12, L1, L2. You have the cluneal nerve, that's the origin for the cluneal nerve coming down. And people who have inguinal pain, lateral hip pain, SI or butt pain, that combination, he attributes that to Main syndrome. And he's a French doctor who researched this. His study he had a pretty good sized study he did, no controlled group. It was all patients with those symptoms, and he would adjust the transitional area and get good results. It's one of those things that it's not heavily weighted in science, but I've tried it on patients and found good results with it. And then people who have a cluneal nerve entrapment in the fibrous tunnel, myofascial work, stretching, deep tissue work on there to free that up. I've found that helpful. But again, there's not a whole lot of science there, but it always comes back to, like with all these patients that are post-surgical, it's an N of one. Don't make them worse. Be gradual in how you work them up, and don't like I said, don't give them a real rigorous adjustment, and you work your way into an adjustment to see what they can tolerate, and always listen to the body. Did it make it better? Did it make it worse?
Absolutely. And actually, I think the listeners should check out Casper Nim's systematic review that just came out on site selection for a clinically relevant site for spinal manipulation. And what they found was there are non-local effects of pain relief with spinal manipulation. And so, like you said, the thoracolumbar junction, that's one of my favorite regions to go after on a patient that had a lumbar spine surgery, because it's safe and you can do a thrust manipulation. There's not going to be any adjacent segment disease, usually in that area. And you can still get a nice relief of pain and relax some of the muscles around that area as well.
And there's several studies that show that adjusting the thoracic spine will reduce neck pain. Adjusting the thoracic spine will reduce shoulder pain. And even though we don't know the mechanism yet, there's something there. Like we talked earlier in our previous discussion about discogenic pain. So one of the things you can do is let's say it's an L4, L5 discogenic pain the person has, and they can't tolerate an adjustment there, adjust their thoracics, and if it makes it better, it makes them better. Can you describe what is the impingement of the descending pathway and how we can affect that? Are you familiar with that?
The descending pathway in the spinal cord?
Mm-hmm.
So as far as sciatic pain goes, I mean, there are a lot of things in the spinal cord that can actually trigger sciatic pain. And some people call that cordonal sciatica. I mean, if you have a case of multiple sclerosis or any kind of spinal cord syndrome, thoracic disc herniation, sometimes some of these descending tracts will get affected. And you can wind up with a kind of a vague lower extremity symptoms that looks just like any other case of sciatic pain. And so is that kind of what you're referring to?
Yeah. And I've heard people say about adjusting the thoracic spine to affect the descending pathway or inhibition of the descending pathways. Have you heard of this?
Definitely. So the descending kind of pain inhibition pathways.
Exactly.
For sure. I mean, we use the spinal joints as a way to provide this afferent input in order to block pain. And that's how I look at it in some aspects. When we're not necessarily honing in on a specific target, we're just trying to get the patient some pain relief, trying to get them some movement, trying to get them feeling better. And sometimes you just use what you're able to use and you do what you're able to do.
We've come to the end of our time here. I'd like to thank you again for joining us. You've been listening to Robert Traeger, the author of Sciatica, Foundations of Diagnosis and Conservative Treatment, an excellent book on the topic. And this is Clinical Rounds.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.